Welcome to the NASM-CPT Podcast and our Facebook Live webcast. My name is Richey, and I am happy to be here with a repeat guest. This is somebody who I've known for a little while now, and I've had the opportunity of working with him because of the new Corrective Exercise Specialist program. And when we're putting together that program, we tapped some researchers on the shoulder that were highly qualified and had a lot of experience doing research and working corrective exercise. And so Dr. Scott Cheatham is back with us today. Welcome, Scott. Good to see you, my man.
Oh, Rick, thank you so much. Again, I'm honored to be in your presence, the podcast man. No, I love it. Thank you. It's great to be here and with all the NASM family listeners. Thanks for being here, and let's hopefully we can share some good information about.
I think we've got a good plan today. So, here's the thing, and this is what's funny is that when we start doing these things, we don't know what we're going to talk about. I just go, hey, Scott will be another great guest. Let's get Scott back on. And so we throw out a few things, and we landed on a particular topic to discuss today. And I had done an Instagram story about it, and I probably had well over a dozen people who did their countdown timer to remind them that this was going on right now. So I hope you're all showing up. I can give you a shout out in a little bit. But thank you for participating. And what we talked about and what the people who have signed up for, they kind of know what's going on, is it is really designed around the corrective exercise specialist, but specifically around a model that you have done research on called the Regional Interdependence Model. So tell us a little bit about that. And then you sent over some research articles, one which I had read before, which is an article that you had written. And then the other one I don't think you have written that you're a contributor to, but it was a good article, and I read through, and it kind of opened my eyes up to more than just like a biomechanical model, but it started adding in the biopsychosocial components along with it as well.
Yeah, so let me try to take everybody through a little story. Does that sound good?
Yes.
Okay. Yeah, kind of a little story. Well, as we know too, when it comes to like rehabilitation, it can be from any, healthcare practitioner. Well, in the 80s and 90s, we were very diagnostic and joint specific. Okay. And I'm going to kind of take everyone through the story so we can see where we've evolved to this model and also how it applies to the new and updated corrective exercise specialist material. So kind of going back to the story. So usually in the 80s and 90s, the orthopedic surgeon or the doctor would diagnose, and they would give us a specific joint. So we would focus on the primary area of impairment, and then that's all we would do. We would not consider regional or remote areas and how they affected that one area. So for example, if I was seeing somebody with a knee injury, in the olden days, we would just focus on the knee. We wouldn't look at the interdependence of how the knee pain affects the hip. Or if we had decreased mobility at the hip, how would that feed into the impairment at the knee? Okay, or distally at the ankle. So back in 2007, there was a group of really good scholarly physical therapists who came out with this regional interdependence model, and they published a paper saying, hey, look, we're so monocular looking at the primary source of impairment, we have to consider remote regions above and below as we are examining and as we are treating clients or patients. And so this model took fire back in 2007, and the article is typically called, by Weiner. Rob Weiner is a really good, amazing physical therapist researcher, and his group put this out, and it caught fire because a lot of us practicing physical therapists and even fitness professionals, we've always looked at the whole body, right? And NASM really promotes that through the observational analysis of the kinetic chain, right? Okay, and we look at it with the kinetic checkpoints. So we've always done this, but in 2007, it packaged it nicely for us. And so then it kind of brought the language back, and it started bringing a whole body of research, started putting everything together. So then ever since 2007, we've had a good 15 years of research that have been looking at treating these remote areas and how it fixed the primary impairment. Okay, so for example, like if the Fit Pro notices that someone is having some poor mobility or an impairment at the hip, we would want them to look at the knee and the ankle and see what is occurring from there. So the model, as we progress and stuff, has enabled us to look at the whole body as one kinetic chain. And I thought it was interesting because even in rehabilitation today, of course, if someone comes in with like an injury or they've had surgery, we initially have to focus on that primary area of pain, but then we're also treating the rest of the body. Does that make sense?
Right? Sure.
Okay, yeah. And I think that that's important. And so this model has grown a lot because we've had some really good research that has shown this neurophysiological interdependence among our whole kinetic chain. Like, for example, there's been many good quality studies that have shown that, if you have a chronic ankle instability, like from ankle sprains and stuff, that actually causes hip abductor weakness. Okay. Another example is we found out that if someone has like a tennis elbow, okay, really simple, that lateral epicondylitis, if we treat the neck, we can eliminate a lot of the symptoms in the elbow. Okay, so we're seeing that there's a lot of research coming out, mainly in like the rehabilitation literature, that's showing, okay, you first have to address the site of pain. Of course, we have to take care of the primary, but then you got to start treating the joints above and below with either mobility, neuro reeducation, kind of getting that whole mobility stability concept going throughout the kinetic chain. And so when we created, kind of started mapping out the new and updated corrective exercise specialist material, we felt that this model as it's grown over the years, was a perfect fit into that whole model approach. So that's kind of a brief history on the regional interdependence model.
So let's talk about that for a little bit. I want to shout out somebody who has one of my favorite names of a company, and it's Dr. Perry Nicholson, and the name of his company is called Stop Chasing Pain. And it was all about this kind of whack-a-mole process of there's pain here, there's pain here, there's pain here. And we could be potentially looking at satellite sites, and we're not really creating assessments necessarily to find what's causing it. So kind of like if I'm firing a projectile and I keep shooting into your elbow, and all you do is try to clean up the elbow, and you really need to stop whatever is creating that projectile firing into it and leading to that pain. You're absolutely right. For physical therapists, vitally important. They came to you to address the pain, but we don't know where that starts, right? I mean, do we have an idea? I think one of the questions I have is, you talked about the ankles, and there's a correlation between ankle sprains and decreased activation in our glute medius or hip abductor pain, or hip abductor weakness. And we see that through multiple different studies. So for instance, the lateral epicondylitis, and then there's a neck issue. What's the chicken and the egg situation here? Is it the weakness in the abductor that potentially led to the roll of the ankle, or was it the roll of the ankle that led to, or does it matter because we know that one feeds the other?
Well, and I think that's a great question. I think it's actually both. I think, there's been a lot of times we've seen with our running athletes that we work with, there's a lot of those kinetic chain overuse issues, right? So I think the process goes both ways. I mean, someone can have an acute injury, but then also someone can have this repetitive overuse injuries that we see with a lot of our athletes and a lot of our runners. So, the $1 million question is trying to see which one caused which. And so, usually it's on a individual basis that once you start working with the client and you start getting more data, and the more you work with them, you start figuring things out. You typically figure out trends, which one came first and stuff. But I would say probably in general, just in a general focus, there's usually some type of kinetic chain issue that affected a joint that was actually kind of like the weak link. Does that make sense?
Sure.
And so unless it's a specific mechanism of injury, it's really hard to say which came about, because a lot of times when we're doing our closed chain activity, multiple joints, our core, our whole body's working at one time. So that would be kind of the next future step on trying to figure out, was it the remote area that affected the primary region of pain, or was it a combination of both? And I think it's a combination of both at this point, so.
Yeah. Well, let me go through this story with you, because this is when I first moved to New York City, which is where I became a personal trainer back in 2002. And I was going through a course, and this person who was educating for the course, and I don't even remember what it was, she was talking about a shoulder issue that she had. And then just kind of dismissively goes, yeah, but that probably came from an ankle issue that I had a few years back. And here I am, in my mind, new to training, new to everything, and I'm thinking, this person is crazy. Everybody wants to connect something to something else. There's no way that a shoulder issue because the person hurt their ankle. And so anyway, fast forward to kind of a deeper understanding of education and knowing the human movement system, you can kind of create links that make sense. But that's a pretty far link there between a left ankle injury or a issue and a right shoulder issue, and creating that link. Is that something that is even possible to happen?
Yeah, I mean, yes. And I think that we're starting to see that when the whole human movement system moves as one unit. Like, for example, one of the prior studies we did is we went out to Arizona and we tested the Arizona Diamondbacks, and we looked at pitching velocity. Okay, pitchers. So we looked at hip mobility in the lead and the trailing leg of pitchers. And we found out that basically, just plainly talking, hip tightness or decreased mobility decreased pitching velocity. They threw less speed when they were stiff. So I think that was one. Yeah. See, so that was one of the first studies where I really started looking and appreciating this regional interdependence concept. Because if you think about the throwing motion and the different 7 phases, and depends on the author, that is a full kinetic chain, full integration type of a movement pattern in a transverse plane. So you're talking one of the most challenging planes to throw a ball. And we found just one of the biggest, the biggest bone, the femur, and the coxofemoral joint, the hip, is the most mobile. If that's stiff, that basically jacks up the kinetic chain up above and below. And if you got a pro pitcher who's basically an entertainer, right? We're paying, and we got our Mondo beer in the stands watching this guy pitch, or this gal, right? We're watching them pitch. Something as simple as a stiff hip, if it decreases their pitching velocity by as similar as 5 miles an hour, that could be their starting position, if you think about it.
Yeah.
So it was interesting when we looked at the pros, and we looked at as simple as, because I don't know about you, but man, everyone, especially during the COVID right now, like 99% of my patients are stiff. You know what I mean? I mean, we're sitting all the time. And, trust me, I'm the poster boy right now for upper cross syndrome, because I'm always like this, and, it's crazy. Right. But I think it's an interesting concept to really start looking at everything as almost like a kinetic chain, and expand it to that. So I think that there is a plausible, to answer your question, sorry, I was a little bit long-winded, but I think that there was a plausible thing that, you got to appreciate how the body's so interconnected, and we're seeing that.
I love that. Hey, just real quick, was Randy Johnson one of the people you got to do an assessment on?
Well, after me and RJ, we call him Randy, hung out. Yeah, no, he was a smidge older. We had some of the AAA boys and the AA, and it was fun. It was a good
Yeah.
time. They're a really good group of guys, and for they were basically our test dummies for 2 days straight. So it was pretty brutal, but really nice group of guys, and they're really into trying to inch out every bit of performance, right? And
Sure.
I think that, yeah, and I think that's important. So
can you speak to something else? I want to stay on musculoskeletal for the majority of this conversation, but there's an article written in 2013 by Suki Cleveland and Weiner, who I believe you had mentioned earlier being kind of like a spearhead of this movement. And they talk about several different things. And this is the Journal of Manual and Manipulative Therapy. And they talk about kind of 4 different parts of regional interdependence. They speak about musculoskeletal, which is really where I want to spend most of our time, but they also talk about somatovisceral, neurophysiological, and biopsychosocial. So can you speak to those other 3 things and then how that affects regional interdependence? And then let's shift our focus back to musculoskeletal, and we'll spend the rest of our time stomping around there.
Yeah, sure. So one thing, just a little history for our family here who's watching, is that so we talked about, like, in 2007, that's when this model came out. Everyone's excited. All this research is coming out. People are connecting the dots. We see it trickle down to fitness professionals, pretty much all movement specialists. Then in about 2013, my friend Derek Sawicki, he's here based in LA. He's an amazing pain researcher, and him and I did our PhDs together. And he got with the original authors, Weiner and Cleveland and all them, and they decided to expand the model now. Okay, so more of a contemporary, because remember, as everyone knows too, we have to stay current with a lot of the concepts that we do, right? And so they expanded the model in 2013 to include other aspects of the whole body. And so what they're saying is that most of us focus on the musculoskeletal aspect of the regional interdependence model, but then they took it a step further. A second. If someone is in pain, it's also going to be somatovisceral, right? I mean, if you're, because we understand what the body is as far as stressors, right? It could be drama in our life, emotional stress, physical, and a lot of us are feeling that right now because we're isolated and we're going through this pandemic. So somatovisceral is a concept of saying, well, wait a second, if your sympathetic nervous system is turned on, you're going to be affecting your whole body. So it's going to be more of a visceral, it's going to be more of the body. So you might feel different sensations, pain or something in the body, but then also too, it could be neurophysiological, because all this kind of stress that we're feeling is coming from our body. So it could affect nerve conduction. It could affect how our brain processes stuff. Then if you kind of go around the model, then it goes into the biopsychosocial, which everyone knows. I think, everybody listening knows that most of our clients that we work with, a lot of times we have to treat this first. We have to really get them to buy into their program, to be more consistent. We want them to be able to enjoy the thought of physical activity again, right? And we want to change behavior. So a lot of what NASM has shown, especially with the new nutritional specialist certification and the updated CES material, is that we have to look at the body as holistic. So this model in 2013, the regional interdependence got a little bit more updated and said, hey, we get the musculoskeletal aspect. Okay, we got it. Now let's step back a little bit. Let's start looking at other things. At the neuroendocrine system. Let's look at cortisol. Someone's under stress. How is it going to affect them mentally, physically? We talk about mental health a lot, right? So and I think this is very intuitive to most of the NASM family, but it's nice to get it on a piece of paper and packaged for us in a nice Amazon box. I gotta
Yeah.
give a joke there. Yeah, right. Yeah, everyone does Amazon, right? Yeah, a nice Amazon gift, so that once we unpack it and we start unpacking it and we start drilling down into all these concepts, then we're like, okay, it becomes very granular. We're like, oh yeah, I get that. I know that, my patient might, let's say they're more sedentary, so they're feeling a little bit kind of down, like in a funk. I know it affects this and that. So it's really bringing together psychology and physiology. Does that make sense? It's kind of bringing together in one package. So, yeah.
Well, if you've not watched, oh man, I can't remember if it's or Mosley, but wonderful pain researchers out of Australia, and he does a TED talk about being bitten by a snake in the bush in Australia. It is brilliant, most wonderful. I love it when you get researchers like you and him that have wonderful personalities that can tell wonderful stories and also have the science to back it. And it's like, man, I want to listen to you. But he talks about this wonderful concept of pain and how the brain creates pain. And so I had a physical therapist telling me one time, he was real big into Butler and Mosley. It's like he was switching his whole thing to no more musculoskeletal. He was just it was almost like a psychoanalytic of everything. And he said, pain is in your brain anyway. And so every once in a while I'd come to him and I would say, hey, I need you to help me out because my brain is making my knee hurt. So if pain is in the brain, but my knee is hurting, there are multiple factors, and musculoskeletal should not be thrown out of that, because I've been to treatment multiple times, and it is musculoskeletal treatments in many instances that have helped me, sometimes just like that, feel better, and sometimes after multiple treatments feel better. So let's dig into this musculoskeletal component, and again, shout out to Butler and Mosley, and one of them, his name is Lorimer Mosley, I believe.
Mosley, yeah.
So Mosley is the one who does the TED Talk. Please go check that out. Again, Australian guy, great pain researcher, talks about being bitten by a snake, and it's going to be a good story. Check that out on the TED Talks on YouTube. But let's get into kind of this concept of musculoskeletal, regional interdependence, and what we can do as fitness professionals, as somebody that's not here to really treat pain. That's not our job. Our job, if somebody is in pain, is to, first of all, avoid pain, and then to recommend that they go see somebody like you, a licensed professional that can help support and treat pain. But that doesn't mean we can't exercise with them or can't work out with them. So we want to avoid that area of pain. We don't want to put them in any more pain, but we can help. And one of the ways that we can help is we don't necessarily treat pain, but we treat movement. We treat movement dysfunctions. We can look at where somebody is weak, where somebody is tight. We can focus on, let's go through the corrective exercise model, right? We can inhibit, we can lengthen, we can activate, we can do integrate. Speak to what we can do as corrective exercise specialists using the regional interdependence model and how we can apply it.
Yeah, so that's an awesome segue into looking at this. So if we focus on kind of like the original, like the musculoskeletal approach, a lot of times when I'm teaching this class to my university students, or just working with patients myself in my clinical practice, one thing I think it's important to understand and appreciate is when a client reports their perception of pain, because remember, pain is a perception, okay? Okay, I think we all have to go back to the basics and realize that our bodies are telling us something, okay? Pain is a sensation. It's an afferent response, okay? So our brain is saying, ow. Right? Simply ow. Then that's going to cause an efferent reaction all the way down from the cortical brain, midbrain, central nervous system to our spinal cord. So we get this huge action, and if you follow Mosley and you follow a lot of this pain research, when people are in pain, obviously it's a stressor. So the sympathetic nervous system kicks on. So basically we have this huge upregulation of the nervous system when we're in pain. Okay, and I think that that's important because as specifically for fitness professionals, in my humble opinion, we always have to kind of identify where the pain is or what it is. Okay, so is it acute muscle soreness after a workout? Okay, that's cool. Or is it delayed onset of muscle soreness? Okay, is it a level of pain that is kind of like that no pain? You know what I mean? So I want to be careful though with fitness professionals who may go out of their scope of practice. We don't want to diagnose. We never want to do that.
Right.
But we do want to kind of identify it. And if they come in with pain, we as a professional and as part of the healthcare industry, that fitness is considered healthcare these days, is that we got to investigate a little bit more, and we have to ask questions, like, okay, what's going on with your pain, and how did this happen? So you want to kind of identify, the mechanism, right? The type of pain, the intensity, and also the aggravating factors, like what's bothering them, but also what's relieving them. So it takes like a minute to kind of go through some questions and figure it out. But I always recommend that every Fit Pro does a stink test. Right? If it stinks, don't do it. Just kind of realize that. So I think the first step is identifying some type of discomfort or pain. Was it just soreness from the exercise and stuff? And then from there, as a professional, then they would determine, okay, it's safe for them to continue with my workouts. Does that make sense? And I think that's important. Now, we're not talking about, okay, I'm sore from the exercises. We want that. Everyone loves to get sore after a workout these days, especially our weekend warrior groups, all the CrossFitters and all this stuff, the HIIT trainers. So we want that, but then also too, we have to realize that as corrective exercise specialists and fitness professionals, we're also experts in movement. Okay, there's a huge body of research that shows that if we move, it helps us decrease pain in the body.
Ooh, okay? Say it again for the people in the back row.
Yes, brother. Okay, brother, Dr. Rick. Yes. So if we move, there is research, especially for low back pain and stuff, post surgeries and stuff. Our bodies are designed for movement. Okay, and that is probably the biggest take home that I can give today is our bodies are designed to movement. If we move, we feel better. Okay, we look at all the physiological things that occur just with human movement, right? The neurophysiological system, the cardiovascular system. And we can just go over a whole hour of just all the effects. We got to move. And so I think this model, when it comes to someone who's in pain, especially musculoskeletal, that's where in the new corrective exercise specialist, or I call it kind of new or updated, the updated material is we expanded our catalog in the assessment flow. And we kind of used the regional interdependence as a foundation as corrective exercise specialists go through their corrective exercise assessment. We're looking at the whole body, and we're doing a combination of, flexibility and mobility tests all the way through. Okay.
So can you speak to that also for just a moment, for us to understand a little bit better, what is that difference between flexibility and mobility?
Okay, well, a lot of times, again, it's almost like, Rick, it's almost like the term functional training. Like, what does that mean? Yeah, I'm going to do functional training. You're like, okay, am I going to garden? Am I going to dig a ditch? Or am I going to throw a ball? Right? I mean, who knows what functional training is? So when it comes to like flexibility, that's kind of a broad term that we use, just kind of saying that it's a combination of, this is, in my opinion, it's a combination of tissue extensibility, right? Your myofascia is able to stretch and lengthen and broaden and all that, but also it's joint mobility, okay? The joint capsule, the ligaments, it's all kind of one kind of 7-layer bean dip. I'm getting hungry right now, right? Yeah, dude, I mean, right? Everything's just all kind of smacked together. So basically for someone to be flexible or to have kind of mobility, they're all kind of interchangeable. Irregardless of the term, you need to have good joint range of motion, right? And that's the measurement of joint mobility. And you also have to have good extensibility and neuromuscular control of the muscles. Does that make sense? So those are the three components that we look at. Is the joint has to be able to move through the full range of motion, the tissues have to stretch, but also you need good motor control. You need good co-contractions, good control, good motor patterns to make the whole system work. So those are kind of the three tenets that encapsulate flexibility / mobility, if that's kind of what we're talking. Okay.
Love it.
Okay.
I like that. I'm actually taking notes right now.
Well, thank you, sir. Thank you, sir. I appreciate it. And coming from Dr. Rick here, I mean, I'm going to blush. Thank you.
I like that. Well, you're giving us kind of a system to follow too. Like here's a 1, 2, 3, 1, 2, 3, and I like that. Sorry, go ahead. Well, I wanted to talk about some specifics of regional interdependence, and this goes back to the research article that you had done back in 2014 at the Journal of Athletic Therapy and Training, and it talks about kind of treatments to one area that help to address issues in other areas. And you talked about the lateral epicondylitis and treating of the neck, or you may have talked about the correlation between weak abductors and ankle sprains. But what are some of the other things that have been found? And these are ways that we as corrective exercise specialists can actually address maybe some flexibility, stability, some strength in certain locations of the body to help people when it comes to issues that they may be having. Again, not necessarily addressing pain, but for instance, I'm not a physical therapist, but I love having conversations with my clients, physical therapists, as they're going to treatment, so that way they can keep working out. But I know that I'm still addressing something that is very important. And something that's also very helpful is that sometimes I might say something that the physical therapist goes, oh yeah, that's actually a really good idea. Why don't we implement that and have that take place? And so whether that's looking at kind of stabilizing in a different plane of motion or addressing a particular region of the body that may not have been addressed, these are all conversations that I have with the therapist, and I want the therapist to have back with me so that I can still do my job. And let's make sure that we understand this. My job is a personal trainer. I am not trying to cross over into physical therapy. I'm not trying to cross streams. I love being a trainer, and I don't want to be a physical therapist. I want to do some really solid, fun exercises. I want to help people lose weight. I want to help people move better. I want to help become more functional, whether that's throwing a ball or gardening or digging a ditch. I want that. But if somebody is addressing pain as a therapist and I can reinforce and support them, I want to do that too. So can we talk about some of the areas like addressing the lumbar spine to treat hip pain or knee pain or patellofemoral syndrome or hamstring strains, or kind of going down some of this list of what you found that certain areas help other areas, and what might be something that trainers can do to help support physical therapists on our end?
Yeah, so why don't we break it down to upper body and lower body? Does that sound good? Yeah. And we'll just do some bullet points for the team, for the family who's watching and stuff. So first of all, when we talk about the shoulder, and I think that's one of the most highly injured joints in athletic people, because we know the glenohumeral joint, right, and the scapular-thoracic, they're very unstable. They really depend on muscular control, right? Yeah. So the first thing to do is what I always tell people, and when I teach this at all levels, I always talk about that the shoulder is all about space. You need to have good posture. You need to be able to correct posture first with any type of upper extremity issue, okay? Second of all is you need to have scapular stability. early scapular stability, in my opinion, my humble opinion, takes care of a lot of issues. You got shoulder impingement, you got your elbow tendinitises, you even have your wrist flexor and extensor issues. You have all that stuff. You have your cervical spine issues, right? Like the text neck, and you have a lot of these postural related disorders. If you restore motion, if you restore proper posture with people, and you get good symmetry in the muscles, and you create that good neutral posture, you create space underneath the shoulder in the subacromial space. You open up the neck, you open up the lateral foramen with the nerves and all that. So you really open things up. So anything with the upper body, one is restore posture. Okay. Number two is create space by getting a more dynamic, symmetry of the muscles to help control and hold that dynamic posture. Does that make sense? Mm-hmm. And I think that that's important because think about this though too. Clinically, I work with a lot of tennis players in Southern California here, right? We've had people with wrist and elbow issues, but it wasn't coming from that. It was coming from a weak shoulder. Okay. It was coming from a weak scapular thoracic joint. So the scapular stabilizers were not stabilizing as they were going through their forehand ground strokes and stuff. All the pressure was going to the elbow and they were opening up during their swing. So the whole kinetic chain was breaking down, because that's why we always go to the tenet of proximal stability first. And that's the core, shoulders, good posture before distal controlled mobility. Okay. And so we've seen that over and over again. And that's been a big theme in the RI, or the regional interdependence research, is saying, look, get good alignment. Okay. Get good strength, motor control, good dynamic posture, whatever we want to classify it. Proximally, that takes care of the extremities, because the muscles will automatically kind of kick in once you have that, and they'll have those good synergistic co-contraction motions in all three planes of motion. Does that make sense?
Love
and
it.
I think, and so that's one of the biggest things we looked at when it comes to the upper body. Again, correct posture, get good symmetry, fix the overactive and underactive. So if we're going to throw the upper body into the corrective exercise continuum, right? Step one is what we do is we always inhibit. Right? Inhibit the overactive. So that means, try to attack those overactive with either foam rolling. They can go get a massage. You can do some other type of inhibitory stuff. Mm-hmm. Lengthen muscles, but those are all locally done, right? Those are kind of local and stuff. Then as you go to step 3 or phase 3 of the corrective exercise continuum, you go into activate. Well, activate becomes more of a regional now, because regional interdependent. So you're going to activate some of the inhibited local scapular muscles, but you're also going to be working the core, the hip, and you're going to be activating that whole kinetic chain. See, so that's where the regional interdependence starts to expand. Then when you integrate, that's when you start doing full body movements. Lunge with the reach. If they're a tennis player, you're going through different sport specific movements that have to do with the whole kinetic chain. Okay. So hopefully, I know we have a short amount of time, but for me, early scapular control, early posture takes care of so many upper kind of quarter upper extremity issues at the cervical spine, shoulder, elbow, and wrist.
And is that one of the reasons also we're seeing such a proliferation of things like thoracic spine mobility, as well as, that's something even a few years ago I never saw really in the fitness industry, except for we would foam roll the thoracic spine. That was a big part of it. But now we're talking about mobility, active range of motion, like all these wonderful things. Do we find that the thoracic spine, a lot of things going on at the thoracic spine also kind of reach out into these other areas?
Yeah, and exactly. And we found out that, now remember too, just here's a perfect example, and we can get deep, maybe in another segment if you want to, but if everyone here is with me and we all kind of flex our shoulder up, okay, we have to remember that the last 10 to 15 degrees actually is influenced by the upper thoracic spine, okay? And then we also understand too that when we rotate our neck, okay, there's been some very good anatomical studies that show that our spine C1 to C7 rotates, but the spine also rotates down to T3. Okay, so we have this cervical thoracic integration whenever we have bad posture, whenever we rotate. So that's why whenever I have personally, when I'm kind of having my PT hat on, if I have somebody with a shoulder issue and I know that they have restriction and hypomobility in the upper thoracic spine, I'll do manipulation to loosen it up. Then I'll take them through the corrective exercise continuum to really retrain. And I'm telling you right now, for some reason, at least for my practice, I'm able to get them out back to the gym quicker than if I just stuck to the old, let's just treat one joint at a time. Yeah. Does that make sense? Okay. So I think everyone who's listening, now we're starting to kind of put the package together, and we're realizing that you got to look at the whole body. And so it should make sense. Like if everyone's with me, if I can kind of expand myself, if everyone has bad posture and they lift their arm up, you can see that you're going to impinge, right? But if you sit up, you have a lot more motion. Right. So we understand through regional interdependence, and it's kind of obvious, but sometimes, like as we're looking in the rearview mirror, things are closer than they appear. Right. Yeah. And I think it's a great analogy, because a lot of times we might look at stuff, but like you said, everyone foam rolls the thoracic spine, but why? What's the why behind it? Mm-hmm. And so the RI model gives us that look at that. And just me kind of talking on the upper body, it makes sense now that, okay, I have to address the thoracic spine through posture, mobility, right? So I need to take basically all the different upper kinetic chain checkpoints through the corrective exercise continuum, and then that takes care of a lot of issues and stuff like that. So for the fit pros out there, if you have somebody who has elbow pain, right, take them through the updated corrective exercise flow and look at thoracic mobility, because we have that in there now. We added that to the new updated material because we wanted people to look at everything from the RI model. So look at the neck, look at this. And also too, I've had many fit pros come to me and say, hey, Dr. Scott, I know you sent somebody with me with elbow pain, but when I move their neck and I do a screen, it's giving them some numbness and tingling down the arm. Ooh. Yeah. So there was one person that they did that, and we just started seeing them. It was like their second session, and the other therapists that were seeing them, I'm like, okay, let me see them. So then we had the patient come back and saw me, and I really started screening the neck, and we found an underlying what's called a stenosis, where he had some wear and tear of a disc, and it was pinching on the nerve. Now he didn't need surgery or anything like that. We were able to safely rehab him, but it's the collaboration between different professionals that work. Okay, so the RI model connects a lot of professionals along the continuum of care. Right. Oh, yeah, and again, I think it's important for the fitness professional to remember that in my humble opinion, the job of a fit pro is to kind of continue where the patient left off in rehab. It's like a baton. Right? It's like we're passing the baton, and so the simplest recipe is just pick up where the physical therapist left off.
That's right.
That's right. It's the safest thing to do, and then you can progress them in the gym and stuff. And most PTs that I know are really cool, and they love a fitness professional, because we realize that we don't know anything, right? I mean, we're learning, and there's so many smart people out there. Right. And so I think it's important, as we look at the RI model and some examples, that we have to be able to expand our catalog of what we know. So the updated material really, is a foundation for really looking at the whole body, which is a more current thing, because, NASM, we're cutting edge. I mean, that's the point. NASM's cutting edge. We always do our best, and as material comes out, it takes a lot of work. We have so many professionals, so many great minds that I work with. Oh my gosh! I mean, I don't know how many times I bowed down to everybody. I mean, Dr. Kyle Stoll, Tony Ambler Wright. I mean, Amy. I mean, all these great professionals. Yourself, Rick. We're always doing this. And so I think everybody here listening, if you guys can get a hold of the new material, it's going to open your eyes to the, a little bit more and kind of build upon that. So with the time we have left, though, at the time we have left, let's talk about lower extremity. Does that sound good? Let's kind of round out our topic.
Yeah, let me just address something real quick. And what it's really about that I want to address right now is about networking as a fitness professional with other people like yourself as a physical therapist, or whether you work a chiropractor or an athletic trainer or whomever it is. It doesn't really matter. And I always say the person that catches the most fish not only fishes in the right place, but also has the biggest net. So for us, we need to expand our network. We need to reach out and reach across and stop saying, as a personal trainer, they're mine, because addressing pain isn't our thing. That's not what we do. We don't have a license to do that. So if we stay in our lane, but we expand our network, then I think we're going to be able to catch a lot more fish, because as you said, more professionals, licensed professionals, are referring out more towards fitness, and fitness is now being seen as a health need and a health must. And so if you can pass the baton as a physical therapist to us over here as personal trainers, then you know that we have a corrective exercise specialty and that we have a background. You're more willing to say, hey, I'm gonna say, our time is done, but if you want to see someone else, these are people that I recommend.
Yeah, and one tenet that I always teach, and I always believed in, is that humility builds bridges. Okay, cockiness burns it. Right. I mean, come on. I mean, everyone knows too in this day and age how much we know. Look at the COVID. We don't know anything. Right. I mean, honestly. Yeah. So I think everybody, I think the fit pros out there, in my opinion, I think that fit pros are becoming, and they need to realize too, is that they are part of the continuum of healthcare, and fitness is so important. So they are bound by HIPAA. And fit pros out there. I'm saying even myself, because I do a lot of fitness. When I'm functioning as a fit pro, I realize that I'm part of this medical team per se. So if you need to call a doctor and stuff, don't be afraid. I mean, you got to function within your lane, right? You got to stay in your lane, and you can't really diagnose. You got to be careful because we're a litigious society, so you got to protect yourself. I mean, that's understandable, but also though too, if it's beyond your pay grade, move the client up to the next pay level, right? Like for me, we see clients direct access in California. So if I do an exam and there's a big medical red flag that comes up, I'm going to send them to an orthopedic because it's out of my realm. And I'm not going to diagnose them as far as, a medical diagnosis, because I'm not medical. I'm physical therapy. So I do a physical therapy diagnosis, right? So I think it's important, like you're saying, is that the networks these days are very symbiotic. Okay, we refer to each other, and I think the fitness professional, needs to realize and that there's no one better than anybody, because there's plenty of clients to go around. I know many fitness professionals who are making way more money than me, and also seeing some very cool celebrities here in California. I'm freaking jealous. You know what I'm saying?
Yeah.
I know, right?
Uh-oh.
Everybody is like, you know what, go on decaf, relax, let's work together, because then it feeds us all. So so I think that there's a new wave of humility that's going around, and but I depend on my fitness professionals, my network that I do. I've trained them in a sense as far as the physical therapy. Like, here's what I want after phase 4 of ACL rehabilitation. I'll send them to the Fit Pro, and so they know what the markers are. But other than that, I trust them to be movement specialists. I trust them to be corrective exercise. All the fitness professionals I work with have their CES, because I told them, I said, you know what, I could probably get you a discount code or whatever, which we did, the stuff. But I made sure that they understood what was going on in the continuum, because that's simply what I asked them. What phase are they in the continuum, right? And then from there, because we know, though, besides the OPT model, corrective exercise is going to be popped in and out of every phase. It depends, because every we always have a joint that hurts. I don't know about you, man. I'm old,
Mm-hmm.
right? I always got something going on. Everybody, if you're active, there's always something. So the CES model will always fit into the OPT model whenever it's needed. Does that make sense?
Sure.
You may introduce a new exercise like TRX, suspension training. Well, you might have to do some correctives with that. Right. So there's so many things that can be fit. So that's where I think, like you're saying, is the networking comes in of just realizing that we're all one team. And I think if we do that more, we'll be able to take care of clients more and more. Plus the monetary helps too, right?
Without
We
a
all
doubt.
make a little, I mean, come on, we got to pay the bills. So
That's
I think that
So can we speak maybe just a couple of minutes on lower extremity, and then if you've got time, and Greg, if you have time, we can open it up to some of the questions that have been asked. But let's hit the lower extremity quickly and kind of run through some things, and then we'll go through some questions that people are asking.
Sure. Yeah. So one of the big things we'll just jump to, because I think the NASM family is pretty strong on the overhead squat assessment, right? So I think that's good. I think we covered that. One of the biggest assessments I love personally is a single leg squat assessment. Okay. Because to me, it tells you three things. Number one, it tells you motor control wise, concentrically and eccentrically, how they can control the lower extremity. Second of all, it also works balance, which we know is three components: eyes, inner ears, and somatosensory. Okay. Okay. The third thing is it really looks at their motor planning and motor control. What is their strategy to do a single leg squat? Does that make sense? So we kind of look at strength, balance, and at their motor planning strategy. Okay. Are they going to hinge from the hip first? Are they going to use a knee strategy where the knee, and we call it knee dominance, is the knee just going to jut forward? Are they going to kind of, because remember, it's movement now, are they going to pronate at the ankle? What is their strategy? So with the single leg squat test, that's my gold standard for most of my lower extremities. Okay. So I do that in all my assessments. To me, very simple. You need to take care of your ball and socket joints. That's it. There's your answer. Okay. If you get, just like the shoulder, if you get early control of the scapular, thoracic, and the shoulder, you take care of everything else in a sense. Okay. Just kind of generally speaking. If you take care of the hip joint, you line up the knee and you line up the ankle. Okay. The femur is the biggest joint in the body, right? Biggest bone. Coxifemoral is possibly people think it's the biggest joint. But if you control the hip in all three planes of motion, you control the femur, you control the knee, and theoretically you control the foot. Does that make sense? Okay, sure. You line everything up. Now, obviously, if someone has static pes planus, which are flat feet, or pes cavus, and then in motion, if they're having some type of we call a flexible foot, and pronate more, or even have a rigid foot, which is supinate. So sure, there's other anatomical things, but as we're talking quickly, if you want to do some really correctives, I always tell people to do the proximal stability first. That includes the lumbopelvic hip complex.
There you go.
Take care of that kinetic chain first. So again, really simply, everyone out there, clear all your kinetic chains. If someone has a neck issue or whatever, clear the upper kinetic chains, then go down to your lower kinetic chains and see if there's any regional interdependence. Does everyone get that? So simply, if we want to package it, take each of your 5 kinetic checkpoints, make sure and check each of them off. Okay, pick the most important one first. So if someone has a lumbopelvic hip issue, let's say they're having hip pain or they're having low back pain, we'll obviously target that kinetic checkpoint first. Then, going by the regional interdependence model, go above and below and get those checkpoints. So it's really easy. Just use your kinetic checkpoints, the most important one first, and then start picking off the other ones. And then that gives everybody who's listening a very nice strategy that automatically incorporates the regional interdependence model. And I know most of the Fit Pros and most of the great minds at NASM, we've always been doing it. This is just a nice package and a nice title that we can use that helps us stay focused. Just like the SAID principle, or this principle of specificity. I always make that miss that up. Being specific.
That was a good effort.
Whatever. I know. I'm like like that. Yeah. So, anyways, everyone gets it. Everyone's like, whatever.
Let's go to Greg for a moment. Let's see if we have any questions for Dr. Scott Cheatham from the group here.
Yeah, we do. Active chat today. Thank you, everybody, for joining us. Danielle in the chat wants to know, regarding a comprehensive posture analysis, do you have a recommendation for posture analysis app or something, a particular software potentially that can be used for my remote clients?
Oh, that's a good question. I mean, I love the Edge app. I think the Edge app covers a lot. There's a lot of posture apps out there. But, a lot of, sometimes simple technology helps, Danielle. And I think sometimes just having, being on a Skype or Zoom and actually having the client stand in front of you, stand at the side and rotate all the way around, and you're doing a head to toe assessment, right? And then recording it and actually looking at it. Sometimes I think that that's the best than trying to use an app that vectors and all that other stuff. So I think remotely, sometimes if you're going to do like a telemedicine type of thing, that's going to be the best, because remember, a lot of times people do their best when they're standing. So sometimes you got to catch them in a relaxed stance, shoes on, shoes off. You have to be specific. If you're working with a runner and they're wearing Hokas, which are big old beefy shoes running, versus small Nikes, that makes a difference in their standing. So I think when you're doing your static and dynamic, sometimes live is better than trying to use an app. I've seen a lot of limitations with the apps because they just take a picture, which is one point in time. I think you need to kind of watch them over a 20 or 30-second period. So that's kind of my thought on that. So hopefully
I'm going to add something to that, Scott.
Sure.
If you guys are watching and you can see the door behind Scott, you kind of can't see much of it, but there's a grid is really nice to have. And so the door behind him, it's got some vertical lines, it's got some horizontal lines. And with that being said, if you have them line up with something like that, or even if they don't have a door like that, but it's just a frame of a door, so you get a nice vertical line and you can see shifting of the body. Having a grid behind people can be very helpful. So is there an app that you can use specifically? Yeah, there's several apps out there, and I'm not entirely sure what they all are, but I'm buying in with what Dr. Scott's saying here, which is, get on a Zoom call or Skype or Hangouts or whatever you can and try to get this live so you can see what's going on and not capture a point in time, but to get some real feedback, some real visual what's going on. And then you can give instruction as well, like make sure you take your shoes off and make sure that you line up, or can you turn this way a little bit? So I like that idea. I think it's a good idea. Greg, what else do we got going on here?
Yeah, Greg in the chat wants to know, he says, I grew up in Arizona. I'm a huge Diamondbacks fan. Who's your favorite Diamondback player you worked with? That Greg is actually me, but I was just interested in finding that out.
It. So. I'm a big RJ fan, man. I love the mullet, and I'm a mullet guy. Randy Johnson had me at hello. So I'm a big Diamondback fan. And remember, out here in Los Angeles, which is the best city in the world, I forgot to mention that. Lakers, Dodgers, who was one of our biggest rivals? Arizona Diamondbacks. So yeah.
Oh yeah. Well, I just remember seeing that clip of Randy Johnson throwing that pitch and hitting the bird that went by.
Yep.
Oh my goodness. There was no pain in that bird's going. That bird just disappeared. So we are real short on time, guys. Hey, Greg, is there any question we can throw out there, or we feel like we need to wrap this up?
No, I think we've exhausted the questions after my selfish one. So I think
okay.
Love it.
Well, we're right at 60 minutes, so I'm going to go ahead and shout out Scott and say, Dr. Scott Cheatham, thank you so much for being on here again. And, I love having you on. I'd like to have you as a kind of a regular guest every month or so to get you in and get your feedback. I think you're, as a researcher, wonderful. You are light and lively and fun to engage with. So thank you for all the work that you've done and committed to NASM and your willingness to participate in what we're doing here.
Yeah, thank you so much. And thank you for the NASM family for listening. And yeah, I would love to come on and talk about hot topics and, whatever. And I'm sure we can, with the membership and stuff, we can come up with some cool ideas. So yeah, hopefully I'll be on soon and we can talk more about hot topics and how they, will better our client care, right? That's the whole point.
I love it.
So, all right. Thank you, everybody.
Awesome.
Yeah.
Y'all, thank you so much for tuning in. My name is Richey. This is the NASM-CPT Podcast.